All right, everyone. So we'll go ahead and get started here. So I'm going to introduce our speaker for today. It's going to be Dr. Michael Johnson. So a little bit about him. He went to undergraduate at Brigham Young University. He then completed his medical schooling at the Arizona College of Osteopathic Medicine, Midwestern University in Glendale, Arizona. He then was a recipient of the Navy Health Professional Scholarship Program and completed his family medicine residency at the Naval Hospital in Jacksonville. He then completed a sports medicine fellowship at St. Vincent's Primary Care Sports Medicine Fellowship in Jacksonville as well, too. And he's currently then at the Naval Station Mayport, where he serves as adjunct faculty for the Naval Hospital Jacksonville's Family Medicine Residency Program. And he is also an assistant professor for the Family and Sports Medicine Program for the Uniformed Services University of the Health Sciences F. Edward Herbert School of Medicine. And then for sports coverage wise, he currently is covering the West Side High School football team and is also an assistant team doctor for the Jacksonville Icemen hockey team. And so we have the pleasure that he's going to be presenting today on the lateral ankle and snapping fibular tendon. So Michael, I'll have you go ahead and take it away from here.
All right, thank you so much for that introduction. I'm excited to get into today's case. Hopefully, this will be beneficial for everybody. I want to try to be brief while still being thorough enough for this quick topic. So quick disclosures. I have nothing to disclose. I do want to note, however, that the views I express today are not necessarily a reflection of the policies or positions of the U.S. Navy, the DoD, or the U.S. government. Here shortly, I'm going to introduce the case of this young man that came into my office. Then we'll review the AMSSM scanning protocol for the evaluation of the lateral ankle. I'll share some of the images and videos from scans outlining the complete AMSSM protocol, and then we can look at the video from the case report that I have presented, and then go over what my documentation looked like afterwards. So let's jump into it. I had a 34-year-old male present with chronic right ankle pain. The pain was on the lateral side of the ankle and associated with an audible pop or kind of a finger snap. He notices the pain worse at the day after riding his stationary bicycle. He is generally active, but less active now than when he was younger. He had multiple sprained ankles and can recall a particularly terrible sprain only a few years ago, but he can't remember if that's when the snapping started or if there were any other injuries that occurred then. He has been in physical therapy previously for this ankle, and he was able to scrounge up his old home exercise plan, and he started that after his ankle was hurting more and more. He worked on stabilization and strength training for this ankle, but it still just remained painful. He hasn't tried to do anything other than the stretching and exercises to alleviate the pain, as he chooses to avoid Tylenol or ibuprofen if he can just deal with it. In my physical exam, after talking to him a little bit, he didn't have any tenderness to palpation, even tenderness behind the lateral malleolus, tenderness at the base of the fifth metatarsal, pertinent structures that are there on the lateral ankle. He had full range of motion, active, and there was only pain with plantar flexion, but it was a mild 2 out of 10 pain. He had full strength, and with when he would forcefully plantar flex and invert his foot, there was an audible snap with every time that he was plantar flexing and slight inversion of the foot. With passive plantar flexion and inversion, there was no recreation of the snap, and there was also no visible dislocation of the fibular tendons over the lateral malleolus. I didn't have a recent X-ray from him, but in his record, as I was combing through it, there was an old X-ray, which is similar to the one that's presented here, showing just a little bit of pes planus, but there were no osseous abnormalities, and nothing that would make me concerned with the 3 views that I had. So as I was listening to his history, I started to develop my working differential diagnosis, which included, but wasn't limited to, fibularis tendon subluxation, intersheath instability of the fibular tendons, posterior ankle impingement, fibularis tendinopathy, and chronic ankle instability, along with other things which were quickly eliminated during my physical exam and further history taking. So these were my leading diagnosis. So let's review the lateral ankle protocol. It is centered fittingly around the lateral malleolus and all of the structures passing around or nearby. The bones that we need to be concerned with are the tibia, fibula, talus, calcaneus, first and fifth metatarsals. The muscles that we'll be evaluating are and need to know their course are the fibularis muscles, the brevis, and the longus. There are other muscles in the area, so those are going to be important, just knowing where you're at and what you're looking for, but we'll be evaluating those fibularis muscles. The ligaments are probably the biggest thing in this lateral ankle protocol, as we'll be evaluating multiple ligaments going from the various tendons or the various bones that we'll be evaluating, and then also the joints. The joint that we will multiple different joints that can be evaluated during this protocol, but the specific protocol requires these 12 items, or should include these 12 items. The fibularis longus and brevis muscles and tendons. We want to look at those in short and long axis. Superior fibular retinaculum, and then a dynamic assessment for fibular subluxation or dislocation as indicated by our HPI, which it was here. Fibular trochlea, or the peroneal tubercle, which is a bony prominence on the talus. The fibula for acute traumatic or stress fractures. Anterior talofibular ligament, including dynamic stress views as indicated. The calcaneal ligament, calcaneofibular ligament, again, including dynamic views. The anterior tibiofibular ligament, which I prefer to call the anterior inferior tibiofibular ligament to differentiate it from the other ATFL. The lateral recess of the tibio-talar joint, including dynamic assessment. The lateral recess of the posterior subtalar joint, the subtalar joint, and then the sinus tarsi, sural nerve, and lateral calcaneal nerve. These are some additional structures which can be evaluated depending on the clinical question you have, and also the particular sonographic skills that you have, because some of these can be difficult, like the bifurcate ligament. And any dynamic evaluation does take some skill to be able to keep that probe steady while there's movement underneath of it. So ideally for this evaluation, you want to use a high frequency linear probe. The hockey stick probe gives you a small footprint when you're evaluating the ankle. But in this case, I actually used your typical MSK linear probe that was 5 to 12 megahertz. And that's what most people will have available. And that's why I chose to do that for this one. Ultrasound is not all that different from your palpation skills. It really is all about knowing the anatomy and being able to visualize it in your mind. Here we actually literally get to visualize it, but that doesn't mean we leave our palpation skills behind. And we just use the probe as an extension. And so really with that probe in our hands, we want to start placing it where we can identify the structure the easiest. the structure that we're most confident about being able to find without the ultrasound probe. So I am a University of Michigan fan. Usually I tell and teach my students that when they're looking for a structure, they need to find the structure that even an Ohio State fan can find. I'll digress on that and say that this time, the structures we want to find are things that we don't really need Connor Stallions to scout ahead for. In the lateral ankle, it happens to be the lateral malleolus. Now, with the indicator on the lateral malleolus, you can see that the two tendons immediately posterior to it, or to the right of it in this image, are the longus and the brevis tendons. The longus is superior or more superficial to the brevis, and we can see a little bit of that brevis muscle. And so here I have them labeled, the fibularis longus, fibularis brevis, and fibularis brevis muscle. And to the right of this on the presentation is just kind of an indication where my probe would be lying on the patient. So in this video, it demonstrates just moving from proximal to distal along that track, and we can see those tendons right next to each other. If we play that video again, as we go down, that fibularis muscle, which is here, disappears. And so on the patient, the probe would be lying in this direction. I have the patient laying on their left lateral decubitus position with a bump underneath of their ankle so that it can be elevated and I can get to all of the positions necessary. I do have my fifth, fourth, and third fingers making contact with the patient to ensure stability during this evaluation. And so the short axis view is also where we're going to see the superior fibular retinaculum. And we'll see that as we're scanning distally and begin to make the turn beneath the lateral malleolus. It comes into view just superior to those tendons. This is the structure that's often injured with repetitive ankle sprains. And if this is no longer present, or if this is not doing its function, this is what allows the fibular tendons to sublux over the lateral malleolus. And here in this view, we can see that the fibular retinaculum is present and would prevent that subluxation or dislocation completely over top of that lateral malleolus. So continuing on with the fibularis longus and brevis muscles, we'll turn our probe just 90 degrees so that we can look at them into the long axis. Fortunately, I didn't catch my labeling error here, but the longus is superior to the brevis, and we can see those fibers running left to right at the top of the screen. In long axis, we can follow these tendons all the way down until we get to the fibular trochlea or that peroneal tubercle. And you can see on the right of my presentation here the location of my probe. And with the probe in this location, you can see the peroneal brevis or fibularis brevis to the left of the fibular trochlea, which is superior to that fibular trochlea, and then the fibularis longus to the right of that trochlea, diving beneath the foot. This is a useful piece of anatomy because it does separate those two tendons in the directions that they go, and allows for us to be able to identify which one if we happen to get lost. In this anatomy picture, you can see how those tendons would course underneath that superior retinaculum and then go to the area with that fibular trochlea right into there. And then if we use our ultrasound probe and just move it, we can follow the peroneal or the fibularis longus as it dives beneath and we continue on to the insertions. We'll first go with the fibularis brevis insertion and finding it onto the base of the 5th metatarsal, which will look something like this as we move towards that base. This is a very superficial structure, very easy to see, and we can get a really nice picture of that. As we go to the longus, and so if we were to go back to that trochlea, follow that as it dove beneath it, we would get into this type of a picture. The longus requires a little bit more focus and can often get lost as it travels beneath quite a few other different structures, as we can see in this picture. The quadratus plantae and the flexor digitorum are more superficial to it, and they are kind of in a short axis coming out of the screen at you in this picture. But we can see those nice fibular pattern of the tendon beneath those structures. And as we follow it, we can eventually follow it as it makes its insertion onto the 1st metatarsal. It is something where some patients are ticklish and it can feel kind of funny. So make sure that you don't get kicked when you're doing this. That's something that has actually happened to me while I was trying to obtain this image. So now we'll move on to the ligaments. The first ligament in question is, and always should be in question when we hear about rolled ankles or chronically unstable ankles, is that ATFL. The ATFL goes from the anterior fibula to the superior talus in a short course, and so placing our probe on that anterior fibular head, we can see it in a nice quick insertion onto the talus. This is one that you can also do a dynamic testing on, and with just traction you can see those fibers lengthening out from and showing really good stability in this case. As we move to the next ligament, it can be a little more difficult to see. Again, we're going to be in more of a short axis on those fibularis tendons, and really just past or just beneath the superior retinaculum, we can see the calcaneofibular ligament as it runs deep to the peroneal or fibular ligaments. When we dorsiflex, that calcaneofibular ligament will actually lift up those two tendons, as we can see right here, the two tendons being lifted by that calcaneofibular ligament. We'll quickly jump up to the anterior inferior tibiofibular ligament as it lies between those two muscles, or those two bones, sorry, and we can view that here with it being intact. We also want to make sure that we evaluate the bones in this area. Of note, the fibula, just because of its ability to have stress fractures. When we're evaluating the bone, we want to go side to side and up and down on that bone to look for any discontinuity in that presentation of the bone. We can move distally towards the plantar surface to bring the calcaneus and talus into view. You would first find the subtalar joint, which unfortunately I didn't capture here, but you can get that anterior tibiotalar joint just moving anteriorly. This is also another area you can view with dynamic testing to see if there's any type of impingement. Just as I was saying, you move a little more distally from this point to where the talus and the calcaneus come into view, and you can see that subtalar joint. If you move just anterior to that portion, you're going to find the sinus tarsi. The sinus tarsi is a tube or a tunnel that is between the talus and calcaneus. And this is a place where we can actually utilize to inject or perform other procedures necessary within that joint space. One of the last structures that we're going to be evaluating here is our sural nerve. So we go back to short axis, and with our probe on the fibula and the Achilles tendon, we can move proximally to see the fibularis brevis and the soleus muscle bellies come into view. Posterior to those, we can see the sural nerve as listed here. You want to follow this nerve as it courses distally, and there you can follow it as it branches off, one of those branches being the lateral calcaneal nerve, which I did not have the image for today. So getting back into our case, a snapping lateral ankle or peroneal intrasheath instability. It's also known as retrofibular intrasheath subluxation, but this consists of an abnormal motion of the peroneal tendons relative to each other behind the lateral malleolus with no superior peroneal retinaculum disruption or previous definite trauma. While performing my ultrasound, I specifically asked the patient to plantar flex and invert their foot to try to recapture that snapping motion, and this is what we found. As you look at this, you have that fibularis longus and that fibularis brevis here, and you can see that fibularis brevis moving anterior to that fibularis longus. Here's another view, a little bit more distal. And again, you have the two tendons right here. And you can see that just move anteriorly with that audible snapping sound. All right. So here's my sample of my diagnostic ultrasound evaluation. The main point is here where I described the fibularis brevis and longus were normal without tendinopathy, tenosynovitis, or tear. Dynamic evaluation showed subluxation of the brevis in relation to the longus tendon within the retinaculum and plantar flexion and inversion. The fibularis brevis attachment on the fifth metatarsal was without tear or cortical irregularities or step off of the metatarsal bone. The fibularis longus attachment on the first metatarsal was without tear or cortical irregularity, step off of the metatarsal bone, with my final impression being intrasheath instability of the fibularis tendons. So in conclusion, no matter what structures that you're evaluating with ultrasound, you've got to know your landmarks. Anatomy is really key. And in this case, knowing that lateral malleolus, positioning being your home base, knowing that the fibular trochlea is an area where we can differentiate those two tendons if we are unsure, and then also being able to find the base of the fifth and first metatarsals or even the medial cuneiform. And of course, knowing the difference between the talus and calcaneus while we're doing our evaluation. Ease of dynamic testing sets ultrasound apart, and this is a particular case study that shows that this is not something that can be evaluated very easily or readily with MRI or CT scan, and is something that you really only can do with the ultrasound. And again, I'll just hammer home technique and positioning, following the protocol and doing it the same way each time so that you don't miss something possible. But most of all, make sure that we have fun while performing these ultrasounds, just because that's really the best thing about being a doctor or sonographer and being able to do these ultrasounds is it's a lot of fun. So I'll open it up. Any questions, comments, concerns, rude remarks? Thank you.
All right. Thank you so much, Michael, for that comprehensive protocol and review the anatomy for this area. Um, Besides me being an Ohio State alum, I appreciated the presentation here. But seriously, though, really comprehensive evaluation. Just a few comments from it. Really like that you kind of highlighted. It is important to scan, the joints. Obviously, in this area, I think sometimes you can get really focused when something's popping or snapping, that it has to be related to a ligament or a tendon in this region. But as you had mentioned, always important to do a comprehensive protocol and just make sure you're not missing a tibio-talar joint effusion, subtalar joint effusion, that may be indicative of more intra-articular pathology, especially in our younger patients where you may have osteochondral defects and things like that that could ultimately lead to some of these feelings of popping. As far as then the pathology of this case, I think more often than not, this is when I see peroneal tendon, snapping, this is the way that I typically have seen it, is the intrasheath, subluxation, rather than, true, full subluxation with a superior retinaculum, injury. So important to note that this is, pretty common, in these patients, especially with that brevis flipping underneath the longus. And then kind of two other things to note is that there is a lot of anatomical variance, with the peroneal tendons as well too, which sometimes can predispose these patients to the snapping. I'd say kind of the two most common for those is going to be a low-lying peroneal brevis muscle, which is going to be something that you'll continue to see past that kind of fibular head, as well as then just a peroneal cordis accessory muscle as well too. And sometimes even peroneal tendon tears can lead to some of the sensations of popping as well too. So those are just kind of some of my few comments, but I'll also open up to anyone else that has any questions or remarks.
Hi, this is Doug Hoffman. I do have a couple comments, remarks. First of all, Michael, nice job. Nice protocol and comprehensive. And I think, one of your last comment, but you do it the same way every time. We should all notice and take heed, because I think that's what's going to lead to being advanced at ultrasound, is just getting used to doing these protocols. Just to highlight Stephen's comment, I do start with the anterior talocrural joint with all my ankle exams, and do it on long axis, short axis, which also gives me the anterior tarsal tunnel and a view of the articular cartilage of the talar head. All that can bring on lateral ankle plantar coexist, particularly in your case where there's a history of multiple ankle sprains. My protocol, I just next go to the ligaments, then I go to the fibular tendons. And as you point out, the lateral subtalar joint and sinus tarsi. And the sinus tarsi, the image you had there was right on. And that's just a nice screening tool for an anterior process of the calcaneus fracture, as well as the bifurcate ligament. So it's a quick and easy way just to screen for that. Just kind of honing in a little bit on the fibular tendons. So there's different zones described. And I'm going to turn on my volume. I just realized it was low. There's different zones described, and there's, I don't find those useful. What I do find useful is divided up into supramalleolar and inframalleolar. And Michael, could you go back to your first short axis slide of the peroneal tendons? So on the supramalleolar area, obviously we're looking at the tendons. We see often the brevis muscle, but then to hone in on the superior or peroneal superior fibular retinaculum. I'm still changing my brain on that. And on that image, you saw that little hyperechoic triangle where the retinaculum went into the fibula. And that's really important, because that tells me that the anchor of the superior retinaculum is intact. And so if you have someone with recurrent ankle sprains, you're going to hone in on that little triangle right there, and those echogenic fibers inserting onto the cortex of the fibula. And so you'll see thickening there when there's been injury to the retinaculum, which can lead to either internal or external instability. And if you scan distally from there, so that's hyaline cartilage. And if you scan distally, that little triangle is going to turn black. And because it becomes, I'm sorry, that's fibrocartilage, and it's going to turn black because it's going to become hyaline cartilage. So don't mistake that as an injury. But when I'm assessing the retinaculum, I'm honing in on that enthesis onto the fibula. So that's really important. And then when we go to the inframalleolar area, as you point out, we should see that brevis muscle disappear. And if it doesn't disappear, you can have either, as Stephen pointed out, a low-lying brevis tendon or a cordis muscle. You also mentioned the superior retinaculum as well as a perineal tubercle. So then that's what I hone in on next. Some people use the number 5 millimeters as normal as far as the height of the tubercle. Again, that's got to be associated with some sonopalpatory pain. And then the inferior retinaculum are fibers that have come from the inferior retinaculum of the ankle, and they come across. And so I always look at those fibers as well because I've seen injury to those fibers. And then if I'm doing a perineal tendon evaluation versus, let's say, a ligament evaluation, then I routinely follow those to the cuboid sulcus and look at if there's a os perineus. And then I also follow it to the brevis to the base of the fifth, as well as get the lateral cord because they have an intimate relationship. So anyway, for me, when I'm doing a fibular tendon evaluation, the retinaculum becomes a really important structure for me. So I just wanted to go over some of those details of that, because as you get more and more familiar with scanning this area, you should just routinely look at that enthesis of the retinaculum onto the fibular cortex. Any other comments?
Yeah, Doug, thank you so much for the kind of detail for going over that for the retinaculum injuries. Really appreciate that. All right. Well, unless we have any other questions or comments, I think we'll go ahead and close this out. We'll be having another presentation, of course, in 2 weeks, and that will be covering insertional Achilles tendinopathy.